Hi everyone, my name is Chebe. I attend Western University of Health Sciences out in Pomona, California. Today I'm going to talk to you guys a little bit about atrial fibrillation. Before we go too in depth about it, let's cover some of the basics. Number one being, why do we care about it? Well, it's by far the most common sustained arrhythmia in the United States. Its prevalence has ranged from 2.7 to about 6 million in 2010. So if we think about that in terms of a ratio, let's just use 3 million for number's sake, divided by the US population. That means 1% of the entire population has AFib, so already it's very common. If you think about it, you're walking on the street, you're driving in your car, you pass 100 cars, at least one of them is bound to have atrial fibrillation. So what are the common associated risk factors? Age, heart failure, hypertension, and a few others right here. So one common buzzword I've heard a lot in medical school is people call it a quiver. Why do we call it a quiver though? It's called a quiver because of non-synchronized conduction. The synchronized fashion is altered, right? So if you think about it, the rate is going to be in 300 to 600 range. Let me scroll down a little bit for us. What is the hallmark of AFib? It's disorganized activation of depolarization, okay? So let's go ahead and draw this out. Let me switch over to the next screen. Change colors. Perfect. Alright, so if we think about normal conduction, we have the SA, we have the AV, we have the bundle of His, Purkinje's, right? So everything happens in a very uniformed, organized fashion. So SA to the AV, bundle of His, to the Purkinje's, and then some accessory fibers. And that allows for maximal ejection fraction. But what's going on in atrial fibrillation is something a little more complicated. Alright guys, so I went ahead and just cleared up that last drawing. So what's going on in atrial fibrillation is we have the SA here, we have the AV, His, Purkinje's. Now we think about our location spatially, we also have the left atrium. So I guess this would be an anterior view. Remember, left atrium has pulmonary veins going into it, right? So an interesting note is that at the pulmonary veins, we find these things called ganglionic plexus, let's call it GPs for short. And they give off electrical conductance in a very disorganized fashion. And it's actually going to go ahead and inhibit the normal electrical conductance. So that leads to something we call the quiver. So what is the theory behind atrial fibrillation? Originally it was hypothesized that it was something related to multiple wavelength theory. Okay, so you get re-entry, and you get re-entry again, and ultimately it leads to just a continuous re-entry. Today, what's more commonly believed to be true is something called the autonomic focus. You might hear buzzwords like driver, ganglionic plexus, right? And they're all referring to this autonomic focus we just mentioned. So we're talking about foci that are giving off electrical conductance, and most commonly they're found at the junction between the pulmonary vein and the left atrium. So pulmonary vein, left atrium. And if we look at this diagram right here, it's a more accurate representation of what I tried to draw out on this previous page. So you see these squiggles, which represent electrical conductance, coming out in a very disorganized fashion, and they're coming from a mother focus, right? So before we go any further, let's just briefly cover the anatomy of the left atrium. To my understanding, most commonly, cardiologists like to orient themselves from the posterior view. So looking at this, I'll simplify it for us. So posterior view. We have the left atrium. Obviously it's not a box, but for simplicity. Right? Here we have the left superior pulmonary vein, left inferior pulmonary vein, right superior pulmonary vein, and then the right inferior pulmonary vein. And as I had mentioned before, let me change colors for us. Right at this junction is most commonly the site of these drivers, or the foci, or the GPs, whatever you want to call them. And again, just to drive home the point, this is the region where we get electrical conductance. So just to reiterate, what is driving atrial fibrillation? Most commonly, it's found at the junction between pulmonary veins and the left atrium. Alright, before we go any further, let's go back to the anatomy of the left atrium just really quick. Just a few things to point out. So, as it's written here, left superior, left inferior, right superior, and right inferior. Another thing that we want to take note of is we've heard a lot about the left atrial appendage, so let's go ahead and check out this LAO view. And right here we see the appendage, we see the superior and the inferiors, right? An interesting note to take note of is that at this in-between region right here in blue is something we call the ligament of Marshall. It's a great buzzword. And we'll cover it a little more in depth further down, but just to give you some spatial orientation. So, very briefly we talked about the junction of the pulmonary veins, the left atrium. What actually is a ganglionic plexus or ganglionic plexi? Well, it's where we get neural input into the left atrium, right? So it's the autonomic nervous system working on the heart. We can also think of it as a driver of fibrillation because it's the most common site. So, as we briefly mentioned just before, another very common site is at the bridge between the left appendage, also known as the auricle, and the left pulmonary veins. So let me scroll up above real quick and just reiterate this point. Again, looking at the LAO view, we have the appendage, superior and inferiors, and right at that circle right here, that's where we get this ligament of Marshall. So, what is the ligament of Marshall? Well, it's actually a remnant of the vein of Marshall. So, an interesting fact is the remnant of the atrial drainage of left atria into the coronary sinus. What I tried to illustrate here is just the posterior view. And we get a nice view of the left atrium as well as the coronary sinus and all the nearby structures. So, we're talking about atrial fibrillation, and it's the most common type of arrhythmia. But we want to ask ourselves, what is an arrhythmia, right? So, a very simple way to think about it is that any arrhythmia is an alteration of either automaticity or reentry. So, what is automaticity? Well, typically we like to think of the sinus node carrying the automaticity, right? The hierarchy being the SA to the AV, His, Purkinje's, accessories. But in arrhythmia, for some reason unknown, we get other parts of the heart that develop this automaticity. And in regards to reentry, if you want more information, we can go back to that multiple wavelength theory. So again, I apologize, let me scroll back up. So again, with atrial fibrillation, there is no definitive theory as to what exactly the pathophysiological process is. So to be complete about AFib and its pathophys as an arrhythmia, we want to say that it's both automaticity and reentry. However, the most important cause of atrial fibrillation are these drivers, these foci, these ganglionic plexuses. Okay, before we go any further, let's just talk very briefly about paroxysmal versus persistent. Right here. So paroxysmal is self-terminating or intermittent. It terminates spontaneously in 7 days or less. And usually it takes less than 24 hours. Now with persistence, what's going on is persistent, is that it fails to self-terminate within 7 days. Okay, so often it requires pharmacological or electrical cardioversion. One thing to take note of is that regardless of therapy, over 50% of individuals with paroxysmal, they ultimately progress to persistent and possibly even permanent. And long-standing persistent, what is that? It's persistent AF, that's lasted for over 1 year. And permanent is a term used to define an individual with persistent AF where a decision has been made by both the patient as well as the physician to no longer pursue a rhythm control strategy. So, why are we talking about this? Why does it matter? Just to try to simplify it, we've talked about these drivers, these foci. How does this play a role, and why does it matter? Right? So if we think about these GPs, a very simple way to divide it is into paroxysmal, excuse my spelling, and persistent. In paroxysmal, you're going to have less foci, and in persistent, you're going to have more. Okay? So it's a progression. So just to read off the notes real quick. Generally speaking, further the AF has progressed, more likely the patient is to have additional drivers. So just to put it back into the left atrium and a spatial orientation, we have these pulmonary veins. These are the most common sites. And the second most common site being the left atrial appendage, also known as the ligament of Marshall. So let me scroll back up real quick. Right here. That's the second most common site. Alright, so we covered a little bit about the background, what is AFib, what is the pathophysiology. I'm going to go ahead in the next section, try to cover some of the left atrium anatomy. And why are we covering the left atrium anatomy is probably a big question. When we go in for something we'll talk about a little later with Diana as well, is ablation. When we're doing ablation, we want to have the most accurate representation of a patient's left atrium. So to do that, we really have to understand our anatomy. So watch out for the next video, and we'll end here.